Good morning. We're here at NewSouth NeuroSpine. My name is Lanier Clark and I do the marketing here, and this is one of our physiatrists, Dr. David Collipp. And we did some research online about what some of the most searched keywords were. And so we thought we'd kick off today talking about numbness and tingling in the extremities. And Dr. Collipp is going to expand on that because he knows a lot more than I do. So here is Dr. Collipp.
Hi, I'm Dr. David Collipp. I'm thank you, Lanier.
You're welcome.
I'm one of the rehab doctors here at NewSouth NeuroSpine. So we're broken into divisions very briefly. We have the surgical division as well as the interventional division, which is principally using medications and injections. We have a physical therapy division that provides therapy, as well as then my division. My division is mostly looking to diagnose and treat from a non-surgical standpoint problems that have to do with the spine and with the nervous system. The nervous system part that we're talking about today is what brings about like numbness and tingling in the hand or numbness and tingling in a lower limb. It can actually be numbness and tingling anywhere, and it doesn't have to be numbness and tingling. It of course could also be like nerve pain. So the underlying concept of this, the underlying problem is almost always going to be that there is nerve involvement. And the question is, why is there nerve involvement? That's the first question that comes to my mind when a person presents and says, I've got numbness and tingling, and then we'll just use as an example in my hand. So numbness and tingling in the hand, again, it's going to be nerve involvement, but the underlying problem could actually be blood vessels. It could actually be some sort of chemical or metabolic process. For example, a person could have diabetes and it would be affecting the nerve in a similar way. In other words, the way that a person would feel it would still be the nerve, but it's not necessarily that the nerve is being, for example, pinched, or it doesn't have to be a radiculopathy, for example. So probably good to go over a few terms. Radiculopathy, because you'll hear that quite a bit, really means that there is damage to the nerve root. Typically, so in the upper limb, you'd be thinking in the neck, and in the lower limb, you'd be thinking in the low back. So radiculopathy means that the nerve root itself is being damaged. Well, what's a nerve root? The root is the part of the nerve that comes directly off of the spinal cord, and then it goes from there to as it is leaving the spinal column. So that's the nerve root. So radiculopathy is damage only to that section of the nerve. Certainly you can have damage to the nerve anywhere along the path of the nerve, but that's what a radiculopathy is. And the reason that we are so concerned about it here, of course, as a spine center, is because it's damage actually of the nerve at the level of the spine. But as I said before, any damage to the nerve, whether it be a chemical damage, whether it be trauma to the what we call peripheral nerve, so away from the spine, like say at the wrist or at the elbow, any damage to the nerve is going to lead to nerve symptoms. So as I was starting to say before, the first thing as a rehab doctor that I want to do is I want to determine what's the likely cause of the person's nerve complaint. It's already understood that it's a nerve because there's numbness and tingling or maybe a burning pain that isn't otherwise explained. So in a very broad brush way of looking at it, we can break it into a few different categories. There's the category where a person has had trauma, for example, and then you'd be looking to see, was the nerve actually damaged in that trauma? So now you'd be talking about direct nerve damage as opposed to some other cause. It can be a vascular cause, like I was saying before, so the blood vessels. And the blood vessels, I mean, interestingly, it can be because of damage to the blood vessel, but it can also be, for example, some people, when they get nervous, just by being nervous, they will start to develop numbness and tingling in their hands. Or a person as a reaction to anxiety, a person with a panic attack, for example, can start getting numbness and tingling in their hands. And it is the nerve that's actually sending that information, sending that signal back to the brain. But what it really comes to is a decrease in the blood flow into the hand the decrease in the blood flow going to the nerve, so that the nerve is now developing numbness and tingling and sending that sensation back to the central nervous system. And then there are disease states that can be associated with it. Probably the most common one that we talk about is diabetes. So we talk about something called diabetic peripheral neuropathy, which broken down means it's caused by diabetes. Peripheral meaning that it's not at the center, it's not at the head, it's not at the spine, but instead it's out at the end of the nerves, so peripheral. And then neuropathy, that word is just broken down to mean neuro, means nerve, and pathos is the disease of. So it's a disease of the nerve that is being caused by diabetes, and the disease is manifest by damage to the nerve out in the periphery, whether in the hands or the feet or what have you. So trauma, as well as disease states, as well as blood vessel dysfunction leading to those problems. There are also certain types of toxins that a person can come in contact with. For example, medications that are used chemotherapy is what we say. So chemotherapeutic agents in treatment of various conditions can also lead then to damage to the nerve. So again, the first thing that we're trying to do is decide what is the cause, and the way that you take that information that I was just talking about is, and proceed to what is the cause of the nerve damage, is to say, how is the nerve presenting? Is it look like it's something that's hitting both feet, for example, at the same time, like coming up to the knees and there's numbness and tingling, and it started a long time ago and it's gradually gone from the toes and it's gradually moving up? That sounds more like a gradual progressive neuropathy versus, for example, and that would be, for clarity, involving the toes and the feet and the ankles and coming up the legs, but all the way around the limb, for example. Versus if a particular nerve has been damaged or a particular nerve is in some way involved. So talking about a lower limb, for example, a person who crosses their legs quite a bit, crossing at the knees such that it can put pressure at a structure known as the fibular head. There's a nerve that runs right past there called the peroneal nerve, and the peroneal nerve can be irritated just by sitting like that. So simply from sitting, you can develop irritation or even damage to that nerve, and I've had patients, of course, who have had exactly that as the cause. They then have not both legs from the knees down numb and tingling, and it didn't start at the toes and gradually come up, but instead they started describing in the area of the peroneal nerve, and only the peroneal nerve, that in that area they started having numbness and tingling and maybe a burning sensation. But it's not in the area of the other nerves that are in the leg. So that part of the leg, and again from the knee down, part of the leg is spared and has normal sensation, and part of it does not have normal sensation. It has these abnormal sensations that we're talking about. So the first is to decide, is it hitting a nerve or is it hitting sort of a larger area? And then to decide if it is hitting a larger area, does it sound more like a disease that's causing that or more of a blood vessel problem? But if it's hitting a particular nerve, that's where we start getting into, is it the nerve being damaged or irritated out in the periphery, for example, at the fibular head, at the knee that I was talking about before, or in the case of the hand, at the carpal tunnel, or in the case of the elbow, at the cubital tunnel. Is that where it's being injured or damaged or irritated? Or instead, is the nerve being irritated at the level of the neck with a radiculopathy? There are differences between those that we would find from a clinical standpoint, not only taking a history and saying, where do you feel this, but also then to ask, and it's in a sense asking on physical examination, where does the person have weakness? Where does the person have a change in their reflexes? Do they have any loss of muscle tone? Is there atrophy within the muscles? Something like that. And then trying to piece that together with where we know the nerve would potentially be damaged in order to have that kind of presentation. In other words, an individual that has damage at the level of the neck will have a somewhat different presentation than a person who has damage at the level of the elbow or the level of the wrist. Now, that's in the grand scheme of things, that's not actually that complicated. It's simply a question of knowing the anatomy of the nerves and knowing which muscles are innervated by which nerves and which area of skin is innervated by which nerves. Because the skin that overlies the muscles frequently is not associated with the muscles beneath them. It's only the skin on top of that, and then it's different muscles. So it's kind of like being Sherlock Holmes and trying to figure out how exactly does this whole thing go together. Well, this kind of interaction that we're having today, this kind of presentation, is going to be much too short to be able to go through all of the different kinds of ways that nerves can be pinched and how to differentiate between them. It takes a little bit more time than we can do in a setting like this. But a common one that we talk about is carpal tunnel syndrome. And that's one that I think affects a large percentage of the population. And it is sometimes concerning that it may be actually a radiculopathy. Again, the nerve root being pinched at the neck as opposed to the nerve being pinched at the wrist. So the wrist is actually here. The wrist is not actually down here. This is the last part of the forearm. The wrist bones are here in the hand, and this is the location where a person has or can develop, carpal tunnel syndrome. The nerve that's involved with carpal tunnel syndrome, for example, is the median nerve. The median nerve travels right here through the carpal tunnel, and then it provides sensation actually for these three fingers, the first, second, and third, or the thumb, the index, and the middle finger, as well as one half of the fourth finger, the ring finger. Many people will come in and say that the abnormality is actually just in these two. Some people will say it's in these three. Some people will say it's the whole hand. And so the presentation doesn't have to be, and very rarely is, quite frankly, that it's these three and half of this one with the other half, this side, being innervated by a different nerve. Very rarely will a person walk in and say that. Much more commonly, the person will say it's either the whole hand or three fingers or two fingers or some combination of that. So the radiculopathy that we think of that would be similar to that is actually the C6 radiculopathy. So the C6 nerve root that comes out between the bones in your neck at C5 and C6 will go principally just to these two fingers. But sometimes individuals will come in and say it's actually going to these three fingers, and sometimes it's going to these four fingers, and sometimes it's the whole hand. And so again, it's partly the history that we receive, partly the information that the person is relating to us, and partly it is also physical examination and then potentially further testing in order to find out, is the nerve being pinched in the neck or is the nerve being pinched at the wrist? To further complicate that, there is also a condition that you can have where the nerve is being pinched at the elbow, and I won't go into a lot of detail about all of the other possibilities, but it does not have to be either the wrist or the neck. There are other areas where the nerves can be pinched. So the first thing to say at this point is, it is a situation where you want to be evaluated. If it's not obvious, you want to be, in other words, obvious to you as you are thinking about how exactly is this running, you need to get evaluated and find out by somebody who has done this a number of times so that they're not thrown by the fact that the whole hand or these two fingers might be associated with carpal tunnel. I've had some people come in describing that these three fingers are the ones involved with carpal tunnel, which are not innervated in that way, but that's their presentation, and they really don't feel the abnormality in these two fingers. So you want someone who has evaluated carpal tunnel syndrome, for example, in the past, and then is also going to look to differentiate between carpal tunnel syndrome and the neck. Now, the majority of individuals, to put your minds at ease, the majority of individuals are going to come in describing probably these three fingers for carpal tunnel syndrome. From a history standpoint, they're going to describe that they've been using their hands quite a bit, either with typing or actually one of the first presentations and diagnoses of carpal tunnel syndrome was in people who were bagging groceries at the grocery store. And that's been many, many years ago, but that was one of the first studies that was done. So that's increased hand work that's going on. Maybe swinging a hammer, or certainly for people with computers nowadays, people doing fine, just very meticulous work with their hands. I even had one fellow that the way that he developed carpal tunnel syndrome was in making baseball caps, which involves bringing your hands down on top of a form that has material on top of it, and you have to bring your hands down forcefully in order to make the shape of the baseball cap, which involved trauma to this area, which led to the carpal tunnel syndrome. So the majority of people that are going to have it, they're going to have some sort of history of use of their hands or maybe trauma to this area. And then it's going to be usually these three fingers, maybe a little bit different, and they probably won't be describing neck pain. Now, before we say you have to have neck pain in order to have radiculopathy, it's important to point out that you don't. As a matter of fact, it is not uncommon for a person to have really no neck pain, and when they are having a radiculopathy, again, radiculopathy, the nerve root being pinched at the neck. When we say pinched, it really should be being damaged or irritated at the neck. It doesn't have to be physically pinched. It can be a chemical reaction that's causing it as well, like we see, for example, with a herniated disc. But at any rate, you don't have to have neck pain with that. You can simply have the symptoms down in the hand or maybe in the forearm that are associated with the radiculopathy, and then the physical findings of areas of weakness and things like that. Let's see. Radiculopathy in the lower limb versus nerve damage in the lower limb. I talked before a little bit about the peroneal nerve that was being irritated at the fibular head, which is on the outside part of the knee. And again, that's an area where an individual can have either irritation or damage to the nerve. It does not need to be from crossing legs, of course. There can be other causes. But that area of numbness and tingling, or potentially even a burning sensation, which would be, again, consistent with the nerve, that area would be also consistent, again, partially consistent, but could be confused with radiculopathy for the L5 nerve root. And the L5 nerve root does come down right into that area. The physical findings can be similar. And again, it is going to require taking a careful history, getting a good physical examination, and being able to determine from that information, hopefully, what the cause is. Sometimes an individual will need to go on for further testing. The testing that we think of for radiculopathy, the one that comes to most people's minds, is going and getting an MRI of the neck or of the low back in order to see, is it the C6 nerve root that we talked about before, or is it the L5 nerve root for the low back that we just mentioned. And an MRI is very good at picking out whether there is a physical, sort of a visible cause for damage for that nerve, but that doesn't actually tell you whether the nerve is damaged. What it tells you is what it looks like. And as I commonly say to my patients, that's sort of like taking a picture of a car and then saying, how fast do you think it can go? Without knowing anything about the engine, without knowing anything about whether it even has gas in the tank. There's more to it than simply what does it look like. Now, I'm not saying that an MRI at that point is unnecessary or that it would be not helpful. Indeed, if a person has had a situation, say an injury, or they woke up and they were having pain going down their leg, the way that frequently happens with radiculopathy, where there is no injury, a person simply develops that. Going and finding out whether there's a herniated disc there, for example, would be very helpful and very important, because it would help to drive the direction of treatment. But there is other testing that has to do specifically with when a person, you're concerned that they are having nerve damage and you want to know, is the nerve actually functioning normally? An MRI doesn't tell you that, and the other testing that can be done for that then is nerve testing. Nerve testing, we happen to be in the EMG room. This happens to be an EMG machine, and yeah, that was planned. So that's an EMG machine. If you've heard about EMGs, please know that they're not as bad as people describe. I would say that, at least in my opinion, they are at least uncomfortable, because what they involve is getting electrical shocks and then getting stuck with needles. And I'm not trying to scare anybody away, but by using electrical shocks and sticking with needles, we're able to actually see, is the nerve functioning normally and is the nerve damaged? And that's really what we're trying to find out. So if a person has a differentiation to be made between a radiculopathy, or a nerve being pinched in the shoulder, or a nerve being pinched at the elbow, or a nerve being pinched at the wrist, and you get an MRI of the neck, you haven't really gained all of the information that you need, possibly. Possibly what you need to do is go and get nerve testing. Now, nerve testing, like I said, if someone tells you about it, they're going to describe it as at least uncomfortable, if not painful. What it actually does is you are sending an electrical signal through the nerve in order to see how long it takes for the electrical signal to pass through the nerve and how much of the electrical signal passes through the nerve. And then you can further from there find out if the nerve is not conducting electricity correctly, where is it not conducting correctly? Is it not conducting correctly at the wrist or at the elbow or through the shoulder area, or does it seem to be coming out of the neck? And the needle part of it is looking to see, is there nerve damage that now can be picked up from the needle? So where does the needle go? The needle goes into various muscles that exist. There are 23 muscles in the hand, there are 20 muscles in the forearm. You don't need to have all of them stuck. We usually get away with maybe sticking 5, 7, 8 muscles, and that's all we need. Because the way that God put us together, not all nerves go in a pattern that maybe we would have come up with, but instead he put it together in a very tricky way, that certain muscles are going to be innervated by certain parts of the nerve, and other parts of the nerve are going to innervate other muscles. And other muscles that seem to be associated with a part of the nerve are not innervated by that. Now that sounds like a lot of words that don't make any sense. I mean, even as they're coming out of my mouth. But here's what it is. If the C6 nerve root is being pinched in the neck, and it could also be carpal tunnel syndrome because you're getting numbness and tingling in these two fingers, the nerve here is not the same as the nerve here. This nerve interacts with other nerves along its path to finally get down to this point where it's going through the carpal tunnel. It goes from being the C6 nerve root to eventually being the median nerve, and parts of the C6 nerve root are going to go to other muscles that are not associated with the median nerve, in the same way that the median nerve has parts that come from other nerve roots. So that by knowing the way that the nerves are set up and the way that what we call the brachial plexus is set up, by knowing the way that that is set up, you can then say if there's damage in this muscle and damage in that muscle and damage in this muscle, that it therefore must be this area of the nerve that's damaged. But if you only have damage in this muscle and maybe a muscle over here, that's a different nerve that you would then think of, even though symptoms might be very similar. So that's the reason for putting the needle into the muscle, is to be able to piece together where the area of damage is. Not the only purpose, but a purpose of it is to see where the damage is. It also, of course, gives you information about the severity of damage, and I guess even the presence of damage to the nerve. Okay, I think it'd be a good idea maybe to open to questions, so I'm looking at Lanier.
Let's talk about some of the medications for, I know that was kind of a topic too, that would treat the numbness and the tingling.
Okay, so that's a very difficult topic. Difficult because there's almost a level of admission that is uncomfortable. So it's going to be broken in, and it'll come in a second, but it's broken into two parts. The first is, are you trying to treat the underlying condition to make the numbness and tingling go away? Or are you trying to treat it the way that we, for example, treat diabetes and high blood pressure and heart disease, or high cholesterol, where we're simply trying to make the situation as good as it can be. Because, as you know, when a person has high blood pressure, we don't give you medication in order to fix the high blood pressure and then you don't have the high blood pressure anymore. Instead, we recommend their diet and exercise, things like that. But instead, we are giving you medication to bring your blood pressure down, but if you stop taking the medication, your blood pressure goes back up. So if you're looking at medications to try to treat the underlying problem, it's going to be medications that bring down swelling, for example, at the carpal tunnel, or bring down swelling at the area of the nerve root being pinched in the neck. But if you're trying to treat the symptoms of it, and this is the part where it gets difficult, for numbness and tingling, we don't have a particular drug that gets rid of numbness or tingling. Now, most people, when they have numbness and tingling, number one, they would prefer to have the problem solved. But number two, numbness and tingling, while it is even potentially very distressing, it's not the same as having burning pain. Burning pain, happily, we have medications that we can use for that. And I don't know whether it's okay to mention brand names versus generic names, but maybe the better thing to do is just say we have several medications that exist that are very good for treating nerve-related pain. So numbness and tingling, we really don't have a medication that stops you from having numbness and tingling. If the goal is to simply bring the symptoms down, we do have medications that might be used to treat the condition to try to make it better. For example, there are some dietary supplements for individuals with diabetes and diabetic peripheral neuropathy, and those supplements can actually reverse the diabetic damage to some extent. It's not complete, and actually decrease a person's symptoms, even of numbness and tingling. But they can decrease the symptoms because they're actually treating the underlying problem. But most of the medications that we have are actually for treating nerve pain. So if a person had nerve pain in the area of the carpal tunnel, as opposed to numbness and tingling, then we have medication that can be used for that.
What about physical therapy? Talk about kind of what you would write to alleviate all of that.
So physical therapy, again, it is, as you can imagine, it is strongly diagnosis driven. The goal of physical therapy, well, I always say that there are two goals of physical therapy. The first goal is to bring about physical improvement, and the second goal is to teach somebody how to be able to do the therapy on their own so they don't need to keep on going back to the physical therapist. Now, there's more that physical therapists do. They have expertise in providing bracing and in doing taping techniques and a great number of other things. I would be trying to take an extremely long list and make it very short, and I would do them a disservice if I suggested that that was their total function. But the point of physical therapy first is to know the diagnosis. So for example, is it carpal tunnel syndrome? I keep on going back to that because it's common. Is it carpal tunnel syndrome, or is it in fact a radiculopathy, a C6 radiculopathy in the neck? And if you're treating the C6 radiculopathy, then it's a question of knowing what is the cause of the radiculopathy, because they can be treated in subtle ways differently from a standpoint of physical therapy. But of course, if you're treating a radiculopathy in the neck and the person actually has carpal tunnel syndrome, or vice versa, you don't get very far in terms of improvement. Now, that said, in the most, I'd say most common, let's talk about carpal tunnel syndrome. The thing that you're ultimately trying to do in physical therapy, and for that matter with medications, is number one, reduce the inflammation around the median nerve in the carpal tunnel. And part of that is to increase the flexibility of the tendons that go through the carpal tunnel, the tendons which are becoming swollen, and there's a swelling area. The carpal tunnel, as the name implies, is a tunnel. So it's a space that has a fixed top and bottom and sides, and the tendons, as they are gliding back and forth inside that tunnel, actually increase swelling within the tunnel that swelling then puts pressure on the median nerve. So the goal of physical therapy is to reduce that swelling, both by having better flexibility of the muscles in the forearm that pass through the carpal tunnel, as well as using modalities, as well as going back and strengthening some other muscles that can be used in order to help compensate for the muscles that are going through there.
Have you ever seen pregnancy-induced carpal tunnel?
Absolutely. Pregnancy, of course, causes, or I think causes as opposed to can cause, I think it causes a certain amount of fluid collection. A woman has more fluid that not only stays within the vascular system, but frequently will go to the carpal tunnel. And so ultimately what you're looking at there is when she has her baby, a few weeks later, usually the carpal tunnel syndrome will actually improve. Treatment during that time, physical therapy can be very helpful. We're not very excited about giving lots of medications. Steroids can be used. And then bracing, which is one of the other things that we do for carpal tunnel syndrome. And bracing so that the wrist is staying at, we say 0 degrees. You'll find that there are some braces for wrists that have the wrist like this. That's called a cock-up splint. This is a different kind of brace. This one is not good for carpal tunnel, but instead you would want to have a brace that was holding your wrist straight. And the idea is to wear the braces certainly at night, because frequently people will describe symptoms at night, but then otherwise, if you are pregnant and you're having carpal tunnel syndrome, you'd want to wear them as much as you could. It's recognized that at the end of pregnancy, when you deliver the baby, what's going to happen is the carpal tunnel, the swelling that's associated with the development of the carpal tunnel syndrome is then going to improve. It's also what we frequently see in trauma. When an individual has trauma to this, to the area of the carpal tunnel, that can lead to carpal tunnel syndrome because of the swelling. But then when the trauma is stopped, typically it just goes ahead and gets better.
Well, good. You think we're covered all the bases?
Okay.
You want to expand any more on anything else?
No,
Okay.
if there are more questions.
Well, thank you all for tuning in this morning with Dr. Collipp. We also have our after-work walk-in clinic. You can come and see one of our surgeons Monday through Thursday from 4 to 6. No referral needed. Just come in after work, walk in for new patients, and we will be able to get you going on a treatment plan. So thank you, Dr. Collipp, for
You're welcome.
wonderful information. Thank you all for tuning in.
Thank you. Bye-bye now.